There you go.
Can you
Hello,
guys
everyone.
hear me okay now?
Yeah, we can hear you okay.
Okay.
Do you want to just go ahead and introduce our doctors? Okay, so Zainab is having technical issues.
Yes, I'll go ahead and do that. So you're
okay.
okay. Yes, and so let me see. Sorry, guys. I don't know what's going on with my computer. Can you hear me okay?
Yeah, I can go ahead. I can just go ahead and introduce them, Zainab. Okay. It's totally okay. Yeah. All right. Well, thank you so much, doctors, for being here. Our Swedish doctors are here. It's that time of month again. And today's topic is we are going over the just debunking some of myths out there as it relates to a women's health. So, doctors, the floor is yours. I will go ahead and make you all a co-host. So, I don't know who's which one of you is going to be presenting, but I'll go ahead and make each one of you a co-host.
Thank you. Yeah, and I can share my screen, Susie. Is that okay?
There you go.
Yeah. Okay. Let me just enlarge this presentation. Can you see that okay? Okay, great.
Yes.
And maybe we'll just take a minute to introduce ourselves. I'm Dr. Katie Schmidt. I'm a second-year resident now at Swedish First Hill Family Medicine, and I'm interested in a lot of topics, including reproductive health care and care for people of color. So I'm really excited to present to this group today.
Hi, I am Dr. Greenman. I am also a second year over at Swedish First Hill. And I am also really excited to be here and see your guys' faces. I have presented with Dr. Abraham before, and it was just such a joy. So I'm back.
Hi, I'm Dr. Abraham. I won't be presenting much today, but I love Mom's Corner, and my passions in medicine include reproductive justice with a focus on bridging the gap of racial health disparities within that field.
Great. And so we'll move forward with our presentation. I think while I'm presenting, if anything comes up in the chat, just like stop me and let me know because I might not see it. And I'll do the same when Dr. Greenman is talking. And then obviously interrupt with questions as well. We want this to be interactive. I'll also try to leave time between slides for questions. But if anything comes up, please don't hesitate to jump in. So our topic today is Mythbusters, and this was requested by your group. So we have come up with a list of myths, most of which were sent in by your group. There are a couple that and it's so hard to see, it's a long list, and our plan is to only address about half of them today because of time. We just don't want to get too detailed and overwhelm you all with information. Our plan would be to cover like half of these, and then we can follow up and cover the rest of the list at a later date. But I really appreciate you all coming up with this long list, and a lot of them are interesting myths that we've also heard, or questions that we've heard from our patients too. So it was really, I think, fun to kind of put these slides together. So myth number one that I'll talk about is you can't get pregnant while you're on your period. I think I've heard this a lot from patients and even from friends. And it is pretty, I would say, pretty unlikely to get pregnant while you're on your period. But it is still possible. So on the left of my screen is a kind of a regular, what we would call a more normal or average menstrual cycle. You can get pregnant before or during ovulation, which is the release of an egg, which then unites with the sperm to become fertilized and become eventually an embryo, a developing fetus. And so, but that ovulation usually happens around day 14 of your cycle, and day 1 is the first day of your period. So can you see my mouse?
Yeah, we can.
Yes, yes.
Okay, great. So day 1 is right here, and that's the first day of your cycle. Usually people like who have an average like month-long or 28-day cycle would ovulate around day 14. But as you can see, the fertility window from when you ovulate is even like 6 or 7 days prior to ovulation. And so the challenge is some people have like very regular cycles, but a lot of people, many people, probably more than half of people don't. And so they may ovulate on, for example, day 10 of their cycle. And if they're on day 4 or 5 of their period, they could most certainly be fertile during that time. And so it is challenging sometimes to know if you're gonna, like, if you are one of those people that is fertile during your period. And there are some people with a higher risk for this to happen. People who recently had their first period, so like young people who just started having periods, usually those periods are less regular and less predictable when you first start in the first few years. Same goes for if you just had a baby, it's also less predictable when you're going to actually ovulate or be fertile. And then if you've recently stopped taking birth control pills or other hormone contraceptives, that also can make your cycle unpredictable. If you're breastfeeding, kind of same principle. And then if you're approaching menopause, so kind of the other end of the lifespan where you're close to stopping periods, often the cycles can get more irregular during that time. And so your ovulation time frame is harder to know if it's going to happen. And then, as I mentioned, if you're some people just do not, even throughout their lives, do not have regular cycles. And so it can be hard to know when they're fertile for those people. The big picture recommendation is if you're wondering when you are fertile, keep detailed track of your periods. You can use apps. There's a whole discussion right now about how the data in those apps is used, which I won't get into, but those apps can be really helpful for knowing when your period is. Or you can even just do old-fashioned pen and paper. Just keep track of like what day you started your period, what day it finished, and kind of the flow each day. And then kind of bring, after multiple cycles, bringing that to discuss with your healthcare provider can be helpful. And then the other big point I like to make is that other methods of birth control besides the rhythm method, which is the method of not having sex when you think you're infertile, other methods are much more effective than the rhythm method for pregnancy prevention. So if that's something that is a goal, I would recommend like kind of a second, thinking about other options, or like a second line option to use in addition to the rhythm method. Does anyone have any questions about this myth?
Nothing in the chat.
Okay. I will move on to the next slide if any questions come up. We also have time at the end. The next myth I thought was fun, was that your vagina should smell like flowers. And I definitely hear that again from my patients, just asking like, why do I have this odor? Is there something wrong with me? So it's a common concern, and sometimes it can be a sign of something wrong, but often it's not. So your vagina is home to an amazing ecosystem of organisms that help keep your vagina healthy and in balance. So we all have, all over our skin, all over the inside of our intestines, and also in our vagina, it turns out, many different organisms that really actually are healthy for us, and like I said, keep things in balance. So vaginal bacteria and other organisms can actually help prevent things like yeast infections and bacterial vaginosis, which are infections that can cause problematic symptoms. But the downside of these organisms is that they often do cause vaginal odors. So here below is a list of common and normal vaginal odors. Some people can have tangy or like fermented odors, and those are due to normal acid produced by vaginal bacteria. So in the vagina, those bacteria do produce an acid that is one of the things that keeps your vaginal ecosystem in balance. But that sometimes can produce an odor. People can also have a body odor or skunky smell. And that can be due to sweat glands in the groin area. I would say of all the different types of vaginal odors, that is one that we can do a little bit about, and I'll talk about that on my next slide. A coppery or metallic odor is often due to vaginal bleeding, and that is very normal if you're on your period or just finishing your period. You might notice that there's a coppery or metallic odor. And then there also can be a fishy odor, which also can be due to normal vaginal bacteria. Can be due to recent penile vaginal sex because sperm can smell like fish. And then bacterial vaginosis or trichomonas can also cause a fish-like odor. And those are actually both infections that I would recommend getting treatment for. And I'll kind of talk about concerning symptoms on my next slide. So before I talk about concerning symptoms, just a couple of notes from us as doctors. It's generally not recommended to douche or use scented products in the vagina. This can actually cause yeast infections or bacterial vaginosis. There's a lot of like products online or even at the drugstore that you can buy to make your vagina like smell better and theoretically make it cleaner. But there's a lot of evidence that those actually can make those organisms I talked about kind of go out of balance and put you at risk for yeast infections or BV, which can just be really uncomfortable and usually like often require treatment if they're causing symptoms. The one thing I mentioned is that for the body odor smell, that's really from the groin sweat glands, like kind of right out, like in the groin area outside of the vagina. So for that, just using a gentle soap regularly with showering, not cleaning inside the vagina. The vagina kind of regulates itself and doesn't need like aggressive cleaning. But just on the outside in the groin area can help with the body odor smell. But it's also very normal, like at the end of the day, to have that body odor smell return. That doesn't mean there's anything wrong with you or that you're not like being clean. And then lastly, I mentioned there are times that I would recommend like seeing your doctor for a vaginal odor, but usually it would be accompanied by things like itching or burning, pain during sex, thick or cottage cheese-like discharge, or a vaginal bleeding that is not related to your period. So those would be signs of maybe something else going on in addition to the odor that I would want you to get evaluated for in the clinic. Any questions about this, Smith?
Doctor, I was wondering about vaginal steaming. Can you speak to that, if that's something that also affects the vaginal imbalance?
Yeah, actually, I might have to look that up unless Dr. Greenman or Dr. Abraham have an answer. I haven't actually experienced that question yet. I think that's a good question though. I haven't looked that up.
Okay.
From my limited experience of vaginal steaming, as long as you're using like clean water and not putting like floral scents, or some people put scented things into the water, then it's okay as long as it's just water.
Mm-hmm. Yeah.
I would just add that, like, I think there's a lot of, like, I just went to this spa that does that, and they don't really tell you what the herbs that they put into that is. And another thing to check is like how hot the steam is, because you don't want to have any burns, things like that. And like sometimes, like, just be aware that like really hot steam, and like whatever is in those herbs can also affect your pH balance as well. So
Yeah. Thank you.
Yeah, because the steam is all the rave these days. I'm sure you guys you all hear about it too. So and just lots of claims about it being beneficial, and you know what I mean, and all that stuff. So that's yeah, I feel like that could take in its own session just to talk about, I've heard a lot about it. I actually went and checked it out a couple years ago myself because I wanted to just experience it. But you're right, heat is definitely a factor in that. And but the person I went, she's also a doula, and so she really is cautious about that. But it's interesting to know. It'll be good to know about some of the herbs they use and how that affects the the whole, because it sweats, the whole area is sweating, so just a difference in the acidity. I think that's an interesting point.
I like to say that the vagina is a self-cleaning oven, and so you don't need to do anything to have a clean vagina. And like odor is part of having a clean vagina as well. It's just like finding the right balance for you.
Yeah, and we can also, for one of our next sessions, I wrote down vaginal steaming to kind of see if we can find any like studies on it or any more, just like more data about it that we can let you know about if we find. I see another question. Oh, go ahead.
No, I was just going to say that this question in the chat, we can also add this to the list to maybe address in a future thing.
Yeah, I think that's a good idea because I think it is a little bit of a separate topic. I think pain during sex should be evaluated. I think it could be caused by a lot of different things. Prolapse can cause at least some discomfort with sex, but I think pain with sex, I would want to do a full evaluation before saying it could be like prolapse in the vagina. But yeah, we could do a more detailed answer of that in a future session as well. Okay. All right, I'm gonna move on. Myth number 3, it is dangerous to exercise when you are pregnant. And again, I've heard this from family friends. I've heard this from my own friends and also from patients. So I think I'm glad that this came up as a question. So generally our recommendation is if you are healthy and your pregnancy is normal, it is both safe and encouraged to exercise in pregnancy. And I'll actually jump to the diagram here on the left, or the picture. There's a lot of different benefits of exercise in pregnancy. Number 1, it reduces pregnancy-related back pain, which especially like later in pregnancy can be really, really problematic and painful. And it's hard because it's a large baby growing inside of you and kind of stretching out all those muscles and putting a lot of strain in places that your body's not used to. So exercise during pregnancy is one of the few things that we have to help with that. Besides like having the baby is another thing that you can do, but you kind of have to wait for that to happen. So this can really help you manage that pain and reduce it during pregnancy. Exercise also decreases constipation, which is pretty common in pregnancy. It improves energy levels, and it helps maintain a healthy weight, which is pretty important for both your health and for baby's health. And it's also associated with like exercise during pregnancy makes it easier to lose weight after pregnancy as well. And it helps maintain heart and lung capacity. And then I think the last one is super important, and one I like to emphasize to a lot of my patients. It reduces the risk of gestational diabetes, so like pregnancy related diabetes, which again, it can be harmful to both mom and baby. It also reduces the risk of preeclampsia and gestational hypertension. which are related to like having high blood pressure during pregnancy. And then it reduces the risk of C-sections. I can say from personal experience when I've been providing care to people in the hospital, the patients who have really engaged in exercise throughout their pregnancy, I mean, it's always hard to predict how somebody's labor is going to go, but often I notice that it seems to be like easier for them to push baby out. And then also, yeah, like it usually takes less time. It's not like a 100% association. And if baby is not coming out quickly, there are plenty of reasons for that besides the exercise question. But I do notice some of the patients that are really fit, I think it really does help them have a little bit of an easier time, which can be, I think, really important because I know that's like such a hard time in labor. So then going back to the right side of the slide, physical activity does not increase your risk of miscarriage, low birth weight, or early delivery. Some conditions in pregnancy, such as cervical cerclage, gestational hypertension, or certain heart and lung diseases, for example, those might be a reason to avoid exercise, especially later in pregnancy. But that recommendation is really individualized and depends like strongly on each condition and your overall health. So ultimately, it's something I would recommend discussing with your prenatal provider. Some patients say with high blood pressure in pregnancy might be fine to exercise earlier, and then in the last few weeks of pregnancy, if their blood pressure just kind of goes out of whack, and they might be recommended to take it easy and not do as much exercise. So it really is dependent on the condition. And there's not really any specific recommendations that I can give. Besides, like overall, most people, I do recommend exercise in pregnancy. Okay, any questions about this myth?
There's a question in the chat, but I'm not sure if it's not related directly to this myth, but it's about people. Is it true that, I don't know, can you see it?
I can see it now. Yeah,
Okay.
I don't always see the alerts if I'm like talking and just not focused on it. But yeah, I see it. So yeah, is it true people who are shorter tend to have preeclampsia the most due to their height? That is a question I actually don't know the answer to. I would have to look up. Yeah, and that is kind of a separate myth, but one that we can talk about in a future session. The more common risk factors that I'm aware of for preeclampsia are prior history of preeclampsia and a prior pregnancy, gestational diabetes, having a higher body weight, or having like a close relative with a history of preeclampsia, smoking. Those are the ones that come to mind. There's more, but we can definitely have a session focused on risk factors for preeclampsia at a later time.
Yeah, I think that'll be a good idea, because we do see a handful of clients who get induced just because they are, they have preeclampsia, and people really sometimes are puzzled as to why that is. Yeah, and just getting the baby out being the treatment and all that stuff. That'll be good. Another one that came to mind, and we'll send email to you all just as you're talking, is I just realized we've never covered about cannabis. I think that would be really awesome to cover cannabis in pregnancy. That's the other one that that we're seeing people using it at the beginning of the pregnancy, or just as a way to eat, things like that. So I think before I forget, I wanted to just put it out there.
Thanks. Yeah, no, those are both really good topics. I wrote those down as well. So I love that. I love these that are coming up and can help inform future sessions. Okay. Next question / myth is about miscarriages. So miscarriages are caused by stress or lifting a heavy object. This is another common concern that I've heard. So miscarriage, just the definition of it, is the loss of early pregnancy. So definitely, so less than 20 weeks of age for the pregnancy. And it occurs in 10 to 20% of all pregnancies. And most miscarriages occur in the first 12 weeks or 3 months. Half of miscarriages, 50%, are due to the embryo which is also a fertilized egg, having an abnormal number of chromosomes or genes. It happens at random, so you can't prevent it or cause it to happen. And so that's at least half of miscarriages are caused by the random chance occurrence. And it can happen just so every pregnancy is a combination of a sperm and an egg. And each sperm and egg is supposed to have 23 chromosomes. But sometimes just out of random chance, when the sperm are being created or when the egg is being created, they might have more or less than that target of 23. And most of the time when they come together, you might be able to have a pregnancy very early on, but those combinations are usually incompatible with life, with continuing the pregnancy. And so at a certain point, the pregnancy just ends, and that's what causes a miscarriage. So that's 50% of the time. Other things that can cause a miscarriage are certain illnesses like severe diabetes or some autoimmune disorders. They can increase your chances of having a miscarriage. If you have a very serious infection or a major injury, like getting in a big car accident, or other major trauma, those can cause miscarriage. And then later miscarriages, the ones that happen after 3 months, may be caused by abnormalities in the uterus. And that's because as the pregnancy is growing, if there is some abnormality in the shape of the uterus, that is usually a factor when the pregnancy is kind of taking up more space in the uterus. So it happens usually more likely after 3 months, not always. And then just of note, if you have had more than 2 miscarriages in a row, then you are more likely to have a future miscarriage. And that's related to some of these things that I mentioned, like certain diseases like diabetes or autoimmune conditions, that unfortunately kind of stay with the person over time. So if you have 1 miscarriage or even 2, that can still be considered normal. But more than 2 would be a reason to think about, is there something going on that is like something medically contributing to this? But there's no association between either stress or like lifting a heavy object in causing a miscarriage. Any questions about that?
In like smelling certain things or like fumes, can that also be I guess a reason why miscarriages occur?
As far as I know, no. I mean, the only exception I would make is if we're actually like a toxic inhalation, like inhaling like carbon monoxide gas or something like that, or other things that we know are actually harmful to your health, to your physical health, that they could then potentially cause harm to the pregnancy. But just smelling a certain type of smell, or like smelling, I would say, like smelling like fumes on the streets, I don't know of any association. I don't ever say no, and like I think that's something that I could look up, but it's not to me a known cause of pregnancy, like I said, unless it's a known like toxic exposure.
Like household cleaning products wouldn't also be one of them?
Correct. Yeah. Household cleaning products. I mean, like I would recommend still, just for like other reasons, to avoid you having a headache or things like that, ventilating, but not specifically like I'm not aware of any association between household cleaning products, inhalation and miscarriage. Yeah. Good question. Okay. All right, and then this is my last slide before I transition it to Dr. Greenman. So this question is Pap smears test for STDs. And it's sort of right, but not quite. So Pap smears actually, so they test for changes in the cervix tissue that suggest cervical cancer or precancer. So what we do in a Pap smear, and if I'm guessing you can still see my mouse, is we take this brush here. It might be hard to see, but it's just a little brush, almost like one that you would use in the kitchen, but it has a little, the middle of it has like longer bristles that actually go a little bit into the cervix. And so what this does is we visualize your cervix and then use this brush to just like lightly scrape off some cells from the cervix. And what that does is then we take that sample and send it to a pathologist who is a doctor that their job is to kind of look at things under the microscope and help us determine if they are normal or abnormal. And so we send that sample of cervix cells to the pathologist, and they tell us if there are abnormalities on your Pap smear. So if the cells look different from normal. The other thing that we do during Pap smears, but this actually does depend on patient age. There are all these like very detailed guidelines for who we should just do a Pap test on versus who we should also do what we call HPV co-testing. And so for certain patients in a certain age group, we will also do HPV co-testing, and HPV stands for human papillomavirus. And that is because certain strains of HPV can increase your risk of having cervical cancer or precancer. And so, and HPV is sexually transmitted, but it is very, very common. It is becoming less common because we have the HPV vaccine, but it is a very common sexually transmitted infection. And you might not have any symptoms of it. And besides, it can cause these changes to the cervix that can put people at risk for cervical cancer. So we sometimes do HPV co-testing. But as a standard, Pap smears do not test for STDs such as chlamydia, gonorrhea, HIV, or syphilis. And there are other STDs I did not list here. But these tests can be done in the same visit as a Pap smear if you have any concern for STDs. So hopefully your doctor discusses this with you, but if not, if you do have any concerns about STDs when you're getting a Pap smear, it is a good idea to say, if they haven't asked you, to say, hey, like I am concerned, I'm having symptoms, or I had a recent exposure that concerned me. Can you do these other tests? Some of the tests are blood tests, but some of them they can actually collect at the same time as the Pap smear. So that's why hopefully they'll bring it up, but if not, then it's a good thing for you to bring up because we don't always do it as a standard.
Awesome.
Oh, I'm looking at the chat. Thank you, Dr. Abraham, for writing all of that. Yes, agreed with all that Dr. Abraham wrote. And then the other thing I always put a plug in for is I do think HPV vaccination is the other big piece of this. So getting the PAPs at the appropriate age, and then also getting the HPV vaccination. There's a lot of controversy behind it, but really it's our like only vaccine that we have that prevents cancer, which is pretty amazing. And so like it's not about the STDs or not, it's about preventing cervical cancer, and people who are vaccinated against HPV have much lower rates of cervical cancer or these precancerous changes.
So with the vaccination, once somebody gets the HPV virus, I know that there's no treatment for it, but sometimes our bodies just get rid of it on their own. If somebody has it and then a couple of years, whatever, down the road, and they're clear of it, can they get the vaccine to prevent future, or how does that work?
Yes, I'd have to look up there used to be a kind of upper age limit for when you could get the HPV vaccine. I know that recently the different bodies that like say who should get vaccinated, they increased the age significantly because there is some data that if you have had HPV, even if you have had it, if you get the vaccine, it can still prevent other strains of HPV, and if you did clear it, it can prevent you from getting reinfected from that strain. I'd actually, and I don't know if Dr. Abraham or Dr. Greenman look offhand, these are the things that I often have to look up, like when I'm seeing a patient. But there might still be some age limits, but I know that it's much higher than it used to be. Like it used to be up to, I think, age like 21 or 25. And now it's like, I can say that I know people in my personal life who have recently gotten an HPV vaccine in their like 30s. So let me check the chat.
Yeah. I think most insurances cover it until age 35 now. And especially if you can like make a argument for other reasons too. And HPV causes a whole bunch of other things, such as like the warts that you see on your hands are often or on your feet. Those are often because of HPV as well. So for people who have a lot of warts, like sometimes I'll advise that they get the HPV vaccine, and it can help reduce the number of warts they have.
Thanks, Dr. Greenman, and thanks, Dr. Abraham, for writing. Yeah, I thought it was in the 40s now that we can recommend it up to age 45. Some insurances still only cover it till 26, but many of them cover it till 45, and I'm hoping that that continues to improve as we have more data showing how effective the vaccine is. Yeah, for sure. Okay. And then, go ahead, Dr. Greenman. I think this is your slide.
Sorry, you did such a great job explaining what it was. I was just, when we're looking at under a microscope, this is what we see for a pap smear. So, a lot of people don't know why we're doing what we're doing. And this is what we're looking at. We're just looking at a random bunch of cells that we took off your cervix, and we're just checking to see if they look normal or not. All right, so myth number 6. The myth is that it's okay to drink alcohol when you're pregnant. And in general, I think basically there is no data to suggest that it is safe to drink alcohol during pregnancy. And every major organization like the American Academy of Family Medicine and the Academy for the OBGYNs and the CDC, everybody says don't drink while you're pregnant. And we know that drinking a lot during pregnancy can lead to things like low birth weight, can lead to things like fetal alcohol syndrome and developmental delays. But there are some studies that have been done that have looked at what happens if you drink a little bit during pregnancy. And there's no good evidence looking at those data, that light drinking during pregnancy negatively impacts your baby. So I think in general for pregnancy, a really good rule of thumb is everything in moderation. And if you really feel like you need a glass of wine when you're pregnant, it's not going to necessarily hurt your baby if you have a glass of wine. But I'd keep it to a glass of wine or two. No vodka shots.
So I was typing something and then I realized that I'm not a fast typer. So I was just going to add also, sorry, Susie, if you have this like as a surprise tip, but if you, after baby is born, there's also no need to do like what people call like pumping and dumping. If you have a drink, the amount of alcohol that is transferred through the breast milk is so low. And we care more about medications that are more like, I guess you could say like fat soluble, because those are more likely to be transferred through the breast milk than alcohol, which doesn't have a high rate of transfer through breast milk. So save your breast milk, don't pump and dump.
Yeah.
So is that like the don't pump and dump? Is that, how much drink does the person need to have? And you know what I mean? Like, because there are people who will have a glass of wine or, you know, whatever, a beer or whatever, but there are people who actually will go to town. So what is that? You know what I mean? And also, do they need to wait for, you know, certain numbers of hours before they can, you know, offer the baby? Like, what does that look like?
I'd honestly have to look up the exact data on that. But I feel like I remember talking about it in one of our residency lectures, and I think you can, you know, get tipsy and even drunk and not have to dump your breast milk just because the rate, like the amount of alcohol that is transferred through the breast milk is so low. But before saying anything like in concrete, I should look up the evidence for that, and I can send that to you. But you do bring up a good question about like kind of like going hard in the drinking. A thing to remember with that, aside from you know, pregnancy and nursing, is making sure that you're safe with baby after you drink. So if you're somebody that is like doing some like close sleeping at times, or like, you know, sideline sleeping with nursing on the bed, that might not be a good time to do that, just because that's when you have higher rates of incidents of like rolling over, suffocation, things like that with the baby, because the drinking has affected your ability, and parents are already sleep deprived, and drinking makes you even more tired. So
Yeah, true. There's a question in the chat box from Marisol. How accurate are the alcohol, like the strip test?
I'm not aware about the strip test unless Dr. Schmidt or Dr. Greenman are, but honestly, I don't think, because of the general evidence is that there's such low amount of alcohol in the breast milk, it's kind of like a gimmicky waste of money thing to test your breast milk. So don't buy those strips and don't drink your milk.
Yeah, I think the IVCLC recommendation is to nurse your baby and then have the drink that you're going to have, and then whatever 2 hours later you can go ahead and feed the baby. So, and not to dump as well. So yeah, awesome.
Okay. So the next myth is that taking birth control makes it harder to get pregnant when you're done with that birth control. And basically, there are a lot of different studies about this, but this is also pretty hard to measure because we're looking at many different types of birth control, and then the amount of time after you stop birth control. There's a lot of different factors, but all signs point to no, it doesn't. So the biggest and best study that was done looked at if you stopped birth control, who was pregnant after 1 year of stopping birth control. And this large study looked at all types of birth control. So people who were on oral birth control, implants, meaning the Nexplanon or IUDs, and people who did Depo. And almost everybody at the end of 1 year was back to the same fertility level as people who hadn't been on birth control. But they did find that people who were on birth control for smaller amounts of time, I just found this really interesting. So if you had only been on birth control for 1 to 3 months, then you were less likely to be pregnant at the end of 1 year than people who had been on birth control for years. So yeah, that, and then people who were on progestin only birth controls. So that's things like Depo, that's things like the IUD, and certain types of oral birth controls, the ones that you have to take at the same time every day. Those were the ones that had the fastest return to fertility. And basically what they think is that estrogen is really the driving factor in terms of whether or not you're ready to get pregnant. So if you really want to make sure that you're not going to mess with that, then you can just go with one of the progestin only forms of birth control, and you'll be back and fertile pretty quickly. And here you can see, so this is the graph that they had. And almost everybody is about 90% at the end of 1 year. Any questions on that one?
Or was the IU one of those? The ones where it takes a while to get pregnant?
Yeah, so the IUD is the green line here.
Oh, okay.
And that actually had one of the quicker return to fertility lines. And I think that's probably because it's progestin only if you're looking at the hormonal one.
But if it's both progesterone and then estrogen, then it could take a bit longer.
Yeah, that's
Okay.
what they're finding. Mhm.
That was interesting, that study you shared about people who were just on it for short periods of time, actually not getting pregnant the longest. That's interesting. I
Yeah,
wonder I wonder
And-
why. Maybe they're just so
exactly.
alert. Yeah.
Like, was it just messing up your hormones and then your body goes, okay, I'm out. I don't want any part of this. I don't know. But it was just something that was like noted in the study. They didn't go into it. So I don't know. Maybe one of you moms can do it. Okay. So the next one is that people who get abortions are more likely to get breast cancer than people who don't. And I actually hadn't heard this one, but as soon as I typed it in, I realized that this is a huge myth and that a lot of people believe this, and that there is a lot of data trying to look at this. But it is really tough to answer, because if we want to make a really good study to see whether or not something happens, we have to make a study where we tell people, yes, you're getting an abortion, or no, you're not getting an abortion. And they don't know whether or not they get an abortion, which is impossible, because then at the end they get a baby or not. So it's impossible to do a really good blinded study on people who get abortions and breast cancer. So most of the studies that we do have are large numbers of people, either keeping data over time, and then you look at people who had abortions at one period of time and then had breast cancer at later periods of time, or they're people who had breast cancer and are looking back in their life and thinking about whether or not they had abortions, comparing that to people who didn't have breast cancer and whether or not they had abortions. So all of this data is really flawed, and we have to keep that in mind when we're interpreting it. But the three largest studies that were done were the first type that I talked about, where they looked at data as it was being taken. So they were all done on European data sets. So it was large healthcare systems. And the biggest one was done in Sweden. So they had all of this information about people who had abortions, and then they just looked to see if those people ended up having breast cancer later on. And what they found, and this was I think it was over 70,000 women, they did not see any increased risk of breast cancer with people who had abortions. And they did actually see a slightly reduced chance of breast cancer in people who had gotten abortions earlier in life, which is really interesting. We know that there is some benefit to not having periods. So like when you're pregnant and not having periods, it's protective in terms of it's protective against breast cancer. So the more periods you have in your life, you're contributing a little bit more to your chances of getting breast cancer. So I found this kind of interesting. I don't know, but like I said, this is really hard to measure. This QR code is a really good paper that Planned Parenthood did it has a whole bunch of studies, probably 20 different studies, and just like one paragraph about each of them. And it includes all of the ones that are both pro and against the argument that people do get breast cancer and don't. And they describe the study and say what's good or bad about the study too, and then say the results. So if you wanted to look at it and see what you thought, you're welcome to. And then Jazz. Yeah. Lower risk of breast cancer if you got pregnant. Yeah. And you know, there is some truth to that, but it is very small. It is a very small change in risk. And you can see the same change in risk if you decide to use like an IUD. And people who use hormonal IUDs tend to 50% of people don't have periods or have very light periods. So there you go. You're going to beat anybody who has a baby there.
I would think it would be like cervical cancer rather than breast cancer. Do you know what I mean?
Yeah, that's true. Ah, I see. It's a good point.
Dr. Abraham, do you have any other pearls to share with us before we move on?
Oh, there's a comment actually in there from Asia. She says breast cancer prevents, what do you call,
Can
breastfeeding prevents breast cancer. Yeah.
So the ICLC, the International, International Conference of Lactation Consultants does endorse that breastfeeding does prevent or decrease the likelihood of getting breast cancer. I have not actually looked at those studies. We can take a look and get back to you about it.
And I agree with Dr. Abraham's suggestion that we should do a breast cancer talk at some point. All right, I'll move on to the next slide.
Okay. So this one is that you would know if your blood pressure is high. And I hear this one all the time. My patients come in and I'm like, hey, did you know your blood pressure is high? And they like, no, my blood pressure is not high. I would feel it. And that's just not true. So here, if you see this table, there are different levels of, high when we say high blood pressure. So a normal blood pressure is anything less than 120/80. Your upper number 120, the lower number 80. And then if it's elevated higher than that, you start seeing damage to some of the smaller veins in the body once you get to 130/90. So this can be damage that can be, it's basically, just think about it like you have really sensitive and fragile capillaries in some of the most important parts of your body. So you have them in your brain, you have them in your kidneys, you have them in your heart, and you're hitting them with a red blood cell at a really high rate. So it's basically you're throwing rocks at the wall over and over again, faster than they should be hitting it. So eventually that wall is going to break, or it's going to build up. It's going to build up a like a scar tissue and become smaller and make it harder for blood to get through. So that's what happens if you have this lower but still kind of high blood pressure. Over time, you're creating this damage to all of these small veins in your body. And you wouldn't feel any of these symptoms of high blood pressure. You wouldn't feel dizzy, you wouldn't feel tired, you wouldn't have headaches or fainting. You wouldn't have those until you get to really high blood pressures, like probably over 180/120. And that's what we call a hypertensive crisis. And a hypertensive crisis is when you have a high blood pressure, and we consider it hypertensive urgency if you also have a symptom of some sort of organ being involved. So if you came in and had a really bad headache or had problems peeing or something like that, that would be hypertensive urgency. So you would only necessarily have symptoms if your blood pressure was really, really high, but you could start seeing the beginning of damage way lower than at the point which you would start feeling those symptoms. So, and the next slide has, so here you can see, So a normal blood vessel looks like that. And then once we have all that blood vessel damage and the sides kind of build up scar tissue because they keep getting hit over and over again by high pressure red blood cells, then you're going to get much smaller, and sometimes they can block off entirely. So if that happens in the brain, sometimes you can get a stroke. If that happens in the heart, you can get a heart attack. And if that happens in the kidney, you end up with kidney damage. And then eventually some people end up needing dialysis. So this is what we are trying to prevent when we are looking at your blood pressure, and why we say it's important to have low blood pressure. So we try to keep everybody, not everyone, we try to keep most people less than 120 over 80 would be ideal, but 130 over 90 would be, I'd be happy with that. Questions about this?
No, doctor, I really appreciate you explaining it in that way, because I think for me, especially, you hear about, you know, the number 120 and over 80, and then like, I don't think most people actually understand what's happening in the body as far as like what's happened to the capillaries and just what high blood pressure means over time. But that really puts it into perspective of like how things are happening.
Yeah, and it can be really scary. On a personal level, my dad had high blood pressure for years, and I was never in his doctor's office, so I don't know what he and his doctor talked about, but I know he wasn't taking medication, and he ended up in the hospital, and they found out that he had 90% of his kidney function was gone because he had untreated, you know, medium but high blood pressure for years. And it wasn't like his blood pressure ever got to the 180s. Like it was always like 140s to 160s. But it went on for so long that he lost most of his kidney function.
God, I'm sorry to hear that.
Thanks. He's doing well now.
Yeah, he's doing, I'm so glad to hear that. But that just goes, because I know some patients, when they come in, you know, they're nervous to see the doctor. So sometimes it just kind of be chalked up to that, or I'm just nervous because I had a doctor's appointment. But what would you suggest, like, for people to do, I guess, yeah, just to kind of keep an eye on that, but what would you recommend?
Yeah, that's a great question. And that is something that we are totally aware of. Like coming into the doctor, it's scary, especially if then maybe you have to do shots later on or do blood. And some people hate needles, and we get that. And if it's the first time or maybe even the second time that we're seeing high blood pressure, I'm not going to sit here and be like, you have high blood pressure, I need to give you meds. I'm going to be like, let's see if you actually have high blood pressure in real life. And it is a great idea for you as a patient to take that responsibility and get a blood pressure cuff, and we can prescribe one for you so you guys can get one, and start measuring your blood pressure at home. So, you know, when you come to the doctor's office next, well, this is actually what my blood pressures have been at home. And if you come in with like a journal of what your blood pressures are, and you can show me, hey, this is just because I'm nervous that I'm here, I will be like, okay, great. I am so happy. Let's go no further. And I don't need to talk about your blood pressure anymore, at least not for another year.
For people who tend to be on the low end, like when they go to the doctor's office, they're not at the 120 over 80, but they're like 102 over 60 or something like that. What about those people?
Yeah, that's a lot harder for people who tend to run lower. I think in general, we tend to underdiagnose high blood pressure for them. And I think that as long as they, you know, continue a relationship with their doctor and their doctor knows what their low blood pressure is, and can help follow the blood pressure over time, then, you know, they can figure it out. But everybody has the same walls of the blood of your capillaries. Everybody has the same walls of your vessels. So even if you have lower blood pressure than normal, your walls are still going to be as strong as somebody who has higher blood pressure than normal. So you can still handle higher blood pressure than what your normal is.
Yeah, and I'll jump in and just say one more thing. Some people do come to me concerned that they run low with their blood pressure. I routinely see people with blood pressures in like the 90s over 50s or 90s over 60s. And I think it really depends on the person. A lot of people, that is just what their blood pressure is. And there's probably a genetic component inherited from their family. And then some people who exercise a lot, that actually over time help your body kind of compensates by having a lower blood pressure and also like a lower heart rate. So sometimes it's actually a sign, for certain people can be a sign of actually being like healthy. I generally like ask a lot of questions about if they're having any symptoms of low blood pressure, like feeling dizzy with standing up, that is like, that doesn't go away after a few seconds, or yeah, like the lightheadedness especially, or just feeling super tired all the time. Like, there could be some symptoms associated with that. That's where we get worried. But usually the people that run low, if they don't have any symptoms, then it usually, like Dr. Green was saying, it can help kind of protect them from some of that damage that we can get if our blood pressures are too high.
These are great questions. Thanks, guys. So the last myth is the myth that cranberry juice can help cure a UTI. So UTIs are something that plague women, and sometimes it makes me so sad that men don't have to deal with this, because I don't feel like they take us seriously when we come in and say that it burns to pee when we pee. But it's because our urethra, the tube through which we pee, so the tube from our bladder to the outside, is only 2 to 3 centimeters long, whereas in a man it can be millimeters, 2 to 3 millimeters, and in a man it can be 19 to 25 millimeters. So it's a lot longer. So if you have a UTI, that means that bacteria has crawled up that tiny little tube into your bladder and has made a whole infection. And guys, just, it's a whole lot harder to crawl up 19 millimeters than it is 3. So the cranberry juice, a lot of people have heard that if I drink cranberry juice, it'll make me feel better. And there were a lot of studies that were done on this, and the studies that were done really early, like in the 80s, there was a bunch of studies that showed that this is true. And everybody was like, that's great. And then people made things like cranberry extract. Recently though, and even like the big review studies at the time all showed that, yeah, it works. But recently there's been about 15 studies that were done that were very good studies that do not show that there is any effect of cranberry juice on UTIs. So what I can definitely say is we know that that cranberry juice is not going to prevent a UTI, that only the data only supports that it will help. If you already have a UTI, it'll help it get better faster. But this newer data, these 15 new studies, if you put them in a lump with all of the old studies, it washes out all of the data and says that there is no cranberry juice doesn't help. But I mean, I think it's worth a shot. Let's see. What about uva ursa for UTIs, or natural root to heal them? Yes, sugar is that is a really good point. I don't know what uva ursa is, but
it's a supplement. I had to look it up.
Oh, thank you.
But you can answer what you want, and then I just looked it up, so I have some thoughts.
In general, though, for any type of infection, keeping sugar low is very helpful. Sugar leads to a more acidic environment, which can help an infection thrive. So trying to keep low sugar, whether it's your diet or your cranberry juice, that will help. But yes, and then Dr. Abraham says the data on ursa is also poor. And Naimo asks, can UTI be left untreated? Any harm with not treating it? That's a really good question. And if there are some cases where a UTI, it will take care of itself and it'll go back to normal and you'll be fine. But there are also some cases where if you have a UTI, that bacteria can crawl up the tube that goes to your kidney and it can lead to an infection of your kidney. And then it can get really bad and you need sometimes IV antibiotics instead of just oral antibiotics. So if you think you have a UTI, I think it's always a good idea to come in and get treated and try to prevent the kidney infection. Because if the kidney infection happens, nobody wants that. And it's also painful.
Yeah. Something else. So yeah, Dr. Greenman, I agree. Like sometimes our bodies can clear UTIs, but it's just hard to know who that will be. And you know, even if that happened to you before, it might not happen the same way again. And the chronic recurrent inflammation that you get from having UTIs, particularly if they're untreated, so they like last for a longer time, can also cause like scarring of the bladder wall, which especially later in life can cause a lot of pain and like incontinence problems. So yeah, so for that reason, and definitely the kidney infection is like the more immediately dangerous thing. We always recommend treating UTIs to prevent those complications.
Isn't there something about UTI leading to like, if not prevented, I mean, if not treated, to like a preterm or something like that?
Yes, with pregnant women, yeah. If you're pregnant and you have a UTI, even if you don't have symptoms, we recommend treating it if we find it in your urine, because it does lead to a higher risk of either preterm labor or miscarriage. Is there a reason why some women are more susceptible to them? So I have not looked at the data for this, but from what I understand, there is a part of it that is anatomic, that if your urethral opening is closer to your vaginal opening, that you are more likely to have bacterial migration into your urethra and you're more likely to have UTIs. But I'm sure that there are a lot of other reasons too, such as, you know, like the shape of your urethra. Is it more curly, dip longer or shorter? Yeah.
Something besides cranberry juice that can be helpful for preventing UTIs for women is urinating after sex. Just because, you know, as we've discussed throughout this talk, there are bacteria that live on our bodies and in our vaginas that they're not infectious to our vaginas or to our skin. But some of them, if they get into the bladder, the urinary system, then they can cause an infection. So peeing right after sex can help if any bacteria did sneak up during sex, then it can help clear it out. So yeah, trying to not completely emptying your bladder before sex and then peeing like right after, it can is associated with preventing UTIs.
And then a lot of these questions that you guys were asking were really great and was based around pregnancy. And I recommend these books by Emily Oster. She writes, so she's an economist, and she became pregnant and basically went to her OB appointments and was very disappointed because she was like, well, why are you making these recommendations? Where's the data behind it? And when her OB couldn't provide the data, she went looking for it. And then she wrote books about her discoveries and interpretations of the data. So it's a fun read, but it also has a lot of really good data-driven answers about things that a lot of people ask, like the exercise question, the alcohol question during pregnancy. It talks a lot about the things that you can't eat during. Expecting Better is all about pregnancy. Crib Sheet is about right after baby's born, birth to preschool. I haven't read Family Firm yet, so I don't know that, but Expecting Better is great and actually changed the way that I practice. So I recommend it.
Thank you for the resource.
And then if you guys have questions, especially related to you or a particular patient, always talk to your doctor for things like if you know somebody who has recurrent UTIs over and over again. Sometimes there are tests that we can do to see if there's something wrong, or if there's something that we can do to make things better. So always feel free to talk to your doctors. Come talk to us if you want. This is our office. And we accept almost all insurances. Any updates on the birth control clinic? What's the birth control clinic?
Yeah, so we just recently started a contraception clinic, and wrote to Dr. Ibrahim about it a few weeks ago, and just in light of the whole, the Roe versus Wade, we wanted to sort of do something for the community, and we figured we keep getting like the need for there to be, in a very non-judgmental environment where people can come and ask questions about various different options, and then possibly a resource to where to get it. So yeah, thank you for following up, Dr. Ibrahim. One of actually our program manager knew a friend of hers who's a student at Seattle U now, and is a practicing nurse at, I think, one of the neighborhood clinics. She just gave the first session. It was just this past Wednesday, actually. And that was in person, but now we are thinking about doing it virtually, or just offering the virtual option as well, just to increase accessibility for folks. So yeah, we'll keep you up to date about that. And thank you for, putting your y'all's address. We do have it, but we'll definitely it will definitely be one of the sites that we are going to be referring folks to, the people who are needing to get just once they choose an option, then the plan is to send them off possibly to you all or to Neighbor Care. I don't know who does that there. So awesome.
Guys, can you share the link
Sure.
for our attendees?
Sure. Oh my goodness. I don't think I have on the computer. There's a flyer that we posted with a pre-pick date that she's going to be doing, but we'll send that flyer out so you can include that in there, Dr. Abraham. Yeah, perfect. Awesome.
And the link to the stipend for
Oh
our
yeah. Okay, I'm gonna send. Give me 1 second for people who attended, because we are trying something different. We appreciate people coming through and attending these things. And we're actually going to be giving people a gift of appreciation for coming. And I'm going to post that link for folks. If you could just give me a second, that would be really great. But other than that, if anyone has any questions, please feel free. I know we are over time with our doctors, but it always happens every time I feel like you all are here. So feel free to ask questions out loud, one or two, and then we'll adjourn.
Wanted to wait and see if someone has a question, but I have one last question, doctors, if you could. And it's just about going back to the blood pressure. When you're measuring the systolic versus the diastolic, can you explain? I've always heard like, oh, the systolic is measuring like the rush of blood against your. Can you define that? Like, what is that measuring, the diastolic and the systolic?
Sure. So the way that we measure it is when we're listening and we have a cuff on, we are putting pressure on your veins at a certain amount, and we're watching the amount as it goes down, and we're listening to the first number is going to be, so we've cut off all blood in your veins. The first number is going to be when we can hear your veins again, when we can hear your heartbeat again. And the second number is going to be when your heartbeat stops again. And basically the top number indicates to us the pressure in your veins when your heart is actively pumping and when it's the high pressure part. So remember, your heart relaxes and then pumps. So if if you're at the high pressure part and your heart has pumped and pushed everything out into the veins, and there's the maximum blood in your veins, what's that pressure at that point? And the low pressure time is when you have the most amount of blood in the heart right before it's about to pump. So that's the second number, the number below. What's the lowest pressure that you're going to see? And that's really very oversimplified, but I think, anything to add, Katie or Jazzy?
Just to clarify, that was really good. Yeah. It's arteries, but yeah. But which are the blood vessels that carry blood away from the heart. And so, yeah, but otherwise, that was really good.
Thank you so much.
Awesome. So somebody texted me earlier. So I'm also looking at my text, people texting questions too. One question, how early does menopause hot flash start and what can help them? I know this is not part of the, but why not? We have you all here.
Yeah, I think we could do a whole talk on that, but we can kind of give some previews. I think so menopause hot flashes, we usually say like menopause is usually lasts for like, I mean, it depends on the person, but usually like the year, like a year or two around when you have your last period. Every person is different. Like I think the average age of menopause, I was just reading, I think it's like 51 or 52 to have your last period. But some people it can be very normal to have that happen in your 40s. And it can be normal to have that happen a little bit later as well. So it's hard to predict exactly like when the hot flashes will start. It usually is associated with either like not like stopping having your periods, or at least having them like start to be more irregular and spaced out. And that time, like right before your period stop, we call perimenopause, and that just means like the time around menopause. So it can happen like a little bit before your period start, stop. But usually it would be associated with either like actually stopping your period or having some really like wild different bleeding patterns. Yeah, and then things that can help, we usually start with what we call like behavior modifications, and it's simple things like not wearing too many layers, or like at night especially, I know people can have hot flashes that can be bothersome. So making sure they're in like a cool environment, sort of like the behavioral things. And then there are some medications that we can prescribe. All medications have side effects, so we try not to go to those first. There's different, like some medications that we even use for like depression and anxiety have been shown to can be helpful for certain symptoms of menopause. And there's also like a whole discussion about hormone replacement, but there are definitely risks and benefits to the hormone medicine. So I don't necessarily recommend those for everyone. So yeah, it's a big topic that I think we could cover in a whole session, but that's my initial answer.
Awesome. Thank you. Thank you so much. We've got so many topics that came out of this, and we're looking forward to the next session with you all. I don't know what we are planning on covering, but we'll definitely follow up. And let us know if there's a topic that you all keep hearing and that you think we should address as well. We'll definitely do that as well. So yeah, it was a great session. Taylor says thank you to you doctors. Yeah, so
It was
awesome.
a lot of fun.
Yeah, it's always fun with you all. Yeah, and we're just thrilled to just be learning this this knowledge from the community, from you guys, and and we hope that this continues, because I think it's really awesome that you all are becoming community doctors, which is to me is a higher honor to have when you're part of a community, and and easily accessible too. So we really appreciate you all.
Thank you.
Yeah,
Thank
definitely.
you so much.
Of course. Have a wonderful weekend.
Thanks, guys.
Thanks, guys.
See you next time.
All right.
Bye.
Bye.